post-acute care settings. Today's presenters are Sarah Slocum and Andy Petrovich, MCEDA LTPAC Health IT Specialists. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for our presenters, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation and a copy of the slides on our website within the next few days. They will be available at www.mceda.org/webinars. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare and Medicaid policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. Today, we will start out by giving you a brief overview of MCEDA and our various service offerings. Following that, Sarah and Andy will take over and provide you with valuable information about the current state of EHR use and what the future holds for Michigan long-term and post-acute care. Following the presentation, they will take time to answer any questions posed by the attendees. Housed within Alterum, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center, tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted nearly 6,000 providers across Michigan, impacting 1.6 million patients annually. Ranked as the 5th largest REC out of a national network of 62, we are also funded by the state of Michigan to assist any provider participating in the Michigan Medicaid EHR Incentive Program. MCEDA's health IT services include the following. Number 1, meaningful use, promoting interoperability support. Providers participating in the Medicaid EHR Incentive Program also benefit greatly by qualifying for state-subsidized services that bring our highly rated technical assistance to you for only $200 per provider, a savings of 96% compared to commercial service rates. Number 2, security risk analysis, which is an embedded service within our meaningful use promoting interoperability support. But if providers only need assistance with the SRA, for example, to satisfy requirements of the Quality Payment Program, we offer it separately as a standalone service. Number 3, attestation and audit preparation. If you are getting ready to attest and just need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of the many folks who have been selected for an audit and need assistance responding, we are here to help. Number 4, our chronic care management program enables physicians to take advantage of the updated Medicare billing requirements for CCM services. We provide you with a dedicated care manager who works within your practice, helping fulfill CMS criteria to maximize your reimbursement potential. Contact us to learn more. And number 5, funded by the Centers for Medicare and Medicaid Services, the Quality Payment Program Resource Center for the Midwest provides free help to clinicians in small practices and rural or underserved areas as they navigate participation in the CMS Quality Payment Program. Go to www.qppresourcecenter.org to join today. With that, I will turn things over to Sarah.
Thank you, Liz. Hello, I am Sarah Slocum, and I'm part of the MCEDA team focused on long-term and post-acute care providers. We bring a variety of backgrounds and expertise related to long-term care and technical assistance to this long-term post-acute care work. Andy Petrovich and I are presenting this webinar today, as Liz said. As a first step in our work, we conducted an environmental scan to learn about the current state of EHR, electronic health record, adoption and use among long-term post-acute care providers in Michigan. and to learn where areas for improvement lay. A key item we learned is that long-term post-acute care providers are motivated by several factors to use EHR, and they see the connection between health information technology innovations and care delivery, as well as the importance of positioning themselves for strategic partnerships across provider types. This graphic depicts where we are now, the current state, and shows inputs toward change, people, process, and technology. These inputs affect the future state, including improved patient care, impact on ratings and reimbursement, and regulatory compliance. By using continuous quality improvement to increase interoperability and move toward a state of optimal function, this process has worked well for MCEDA, and we expect it to work well for long-term post-acute care providers. In our study of EHR use and the needs of long-term post-acute care providers, we learned there are two prominent areas of improvement: care transitions and medication management. In the past, the Federal HITECH Act provided a framework for health information technology development and incentive funds to make improvements and achieve interoperability. But providers included were hospitals and physicians, not long-term post-acute care. Now the federal government, in the Office of the National Coordinator for Health Information Technology, or ONC, is giving states more flexibility in the types of providers to work with. And ONC and states recognize the need for interoperability between eligible providers and long-term post-acute care providers to optimize patient care. Additionally, the federal 21st Century Cures, C-U-R-E-S, Act put even more emphasis on full interoperability and promotes full patient-level data sharing between hospitals and other providers, including long-term post-acute care. As CMS looks to tie payment to performance, providers will need data to demonstrate their measures and to maximize reimbursement in value-based payment systems. CMS is also looking at changes to the 5-star system, which of course will require data to calculate, and measures about readmission rates and short-term rehab measures are coming online. CMS has delayed the readmission measure in order to revise it, but other measures are moving ahead. All of these initiatives will require good data based on maximum utilization of EHR systems. Now some additional details about value-based purchasing. CMS will look at hospital readmissions from skilled nursing facilities within 30 days of admission. Each skilled nursing facility will receive a performance score comparing them to other skilled nursing facilities in the country. They will get quarterly and annual confidential performance reports. How did they do on this measure? And depending on their score, based on the skilled nursing facility's performance, they can get reimbursement incentives. Some key changes to the 5-star system are based on the fact that the new skilled nursing facility survey system will begin to feed data into the 5-star ratings. Also, staffing is now calculated using payroll-based journal data, and RUGS scores, risk-adjusted and related to the amount of staffing needed to meet the residents' needs, will all come into play. Providers who can optimize their EHR use will likely fare better on these measures. Next, some details about short-term rehab measures. These new measures are about mobility and self-care, and improvements are expected for many people during their short-term rehab stay. In Michigan, the Department of Health and Human Services has recently turned attention to improving interoperability and connectivity for long-term post-acute care providers through technical assistance from MCEDA, attention to benefits for vulnerable populations served by long-term post-acute care providers, and seeking to meet patient expectations for seamless care delivery across multiple settings and providers. Finally, the Michigan Certificate of Needs Standards award points in competitive review applications for EHR adoption, another business reason to improve use of EHR and interoperability. Next, we'll talk about two examples of ONC-sponsored pilot projects in other states. First, in Louisiana, a 120-bed skilled nursing facility adopted enhanced connectivity. They used technology to upload vitals and weights in real time to their EHR system and used telehealth to communicate changes. Camelot's goal was to reduce their 26.3% hospital readmission rate. The intervention specifically was to provide 24/7 monitoring of vitals for post-hospital residents, develop a care protocol for all post-hospital residents, and use proactive measures to address change in condition. Within a year, Camelot brought the readmission rate down to 10.4%. In a project called Coordinated Care Oklahoma, providers achieved notable quality improvements. 5 long-term post-acute care providers and 1 hospital participated in a 20-month pilot in 2013 and 14. They used ADT, admission, discharge, transfer, notifications, referral management, and transition document exchange to increase the flow of patient information among providers. Using real-time information on patient conditions, they achieved a 98% compliance rate from CNAs in doing daily patient assessments, 97% patient satisfaction rate, 78% lower 30-day hospital readmission rate, 70% lower 30-day return to the emergency department, and a 50% lower readmission rate within 12 months of the hospital stay. All of these technology-based efforts are ultimately aimed at improving patient care and safety. The patient is at the center of all these improvements, and achieving better health outcomes and better patient satisfaction with seamless transitions of care helps position providers for strategic relationships with other provider types and some rating and reimbursement gains. Next, Andy will discuss the current state of EHR among Michigan long-term post-acute care providers. Andy?
Thank you, Sarah. Clearly, adopting and using health IT can lead to significant improvements for providers and patients. In our review of national trends, we found clinical personnel reporting positive experiences in their use of EHR technology, citing positive impacts on workflow and efficiency in particular. We wanted to know more about the experience of Michigan providers in long-term and post-acute settings using electronic health records. So we performed an environmental scan to better understand the experience of long-term and post-acute care providers' use of EHR systems. Our research involved reviewing literature on national trends, analyzing quantitative and qualitative data, interviewing industry experts, and performing a statewide survey of long-term and post-acute care providers. This information revealed trends in long-term and post-acute care providers' EHR experience. We looked at implementation and utilization of EHR systems, how those systems are used to facilitate health information exchange, and what long-term and post-acute care providers are looking for to get more out of their systems. So now we'll share some of those key findings with you. One focal point of our research was around the adoption and implementation of EHR systems, including the availability of EHR products for long-term and post-acute care settings. At this point, we'll note that, based on conversations with industry stakeholders, the term EHR may be variably understood. The terms EHR and EMR, or electronic medical record, are sometimes used to represent different types of systems, but we have found that this is not a precise distinction. These terms are also commonly used interchangeably, So for the purposes of this presentation, we will stick with the term electronic health record, or EHR. Long-term and post-acute care providers have multiple EHR products to choose from, with the most popular EHR systems in use also being certified as certified EHR technology by the ONC. This indicates that these systems have potential for interoperability with EHR systems used by other healthcare providers who can connect with certified EHRs in use by long-term and post-acute care providers, for example, to meet promoting interoperability objectives. Many long-term and post-acute care providers are accessing EHR systems from nearby hospitals in a limited capacity, while some providers have adopted their own systems internally. Providers who implement their own EHR systems are generally looking to modernize their operations in addition to improving the availability of patient data, therefore seeing the systems as an investment. Despite most long-term and post-acute care providers being ineligible for the EHR incentive programs, which are commonly called meaningful use, adoption rates are still found to be high, both nationally and in our home state of Michigan in particular. Long-term and post-acute care EHR adoption in Michigan is very high, with what we found to be 94% of respondents in our survey, indicating that they have an EHR system adopted throughout or in some portion of their organization. A recent ONC survey found national EHR adoption rates among long-term and post-acute care providers to be between 66 and 75%, showing that long-term and post-acute care providers in Michigan are well ahead of the national average. Michigan's high EHR adoption rate is attributed, at least in part, to Michigan's Certificate of Need process, awarding points for EHR adoption and use, as well as our robust health information exchange infrastructure. While Michigan long-term and post-acute care providers are ahead in terms of EHR adoption, this finding is aligned with the national overall trend of increasing rates of EHR implementation. So we expect that over time, EHR adoption will continue to rise nationally, and eventually the 94% that we see here will be closer to what we see overall. While the vast majority of long-term and post-acute care providers have adopted EHR systems, how they are using those systems varies considerably. Our research has shown that organizations focus on different capabilities of EHR systems according to their specific priorities. It's not common to see the full functionality of a system comprehensively in use. It's more common to see piecemeal functions utilized as needed. The most mature EHR utilization was observed among those organizations whose health IT infrastructure was centrally managed by, for example, administrative, corporate, or professional IT personnel. We find that long-term and post-acute care providers are using their EHRs in a limited way overall, using only a small subset of the functionalities their EHR systems possess. This table highlights the most popular functions reported in our survey, which are medication management and physician orders, typically. Long-term and post-acute care providers are finding ways to use their EHR systems to meet their needs. The popularity of these options shown here highlights the importance of high-integrity documentation around medication management and physician orders, as well as the usefulness of EHR systems to meet these needs. However, EHRs can be used for more. While there are many direct and indirect benefits incentivizing the adoption of EHR, comprehensive and full use of the range of capabilities offered by the EHR has not been strongly incentivized in the long-term and post-acute care field. And in many cases, providers may not even be aware of all the possible EHR functions that they could be utilizing. We also looked at long-term and post-acute care health information exchange, or HIE, in Michigan. There is a strong incentive for providers to participate in HIE, as long-term and post-acute care providers need to become interoperable with hospitals, clinics, and health systems to be recognized as preferred referral recipients by those other providers. Health information exchange has also been shown to improve outcomes related to transitions of care, which is a major pressure point for many providers. We found that the most mature health information exchange was among those organizations whose health IT infrastructure, again, was centrally managed by administrative, corporate, and/or professional IT personnel, similar to maturity of EHR utilization. This table highlights the moderate utilization of HIE among long-term and post-acute care providers in Michigan per our survey findings. Many respondents reported using some HIE functions, but the utilization rates for each, even the most popular functions, are still fairly low when compared to the overall rates of adoption. The most commonly reported HIE functions are related to radiology reports, lab reports, and exchanging admission, discharge, and transfer, or ADT, information with outside entities. Most commonly, those are hospitals and pharmacies. And this table shows the number of long-term and post-acute care organizations by type. And here we have skilled nursing, home health, inpatient rehab, and long-term acute care represented, participating in each of the listed HIE functions, based on information directly obtained from the Michigan Health Information Network. HIE rates are seen to be fairly high among skilled nursing facilities and inpatient rehab, somewhat lower for long-term acute care, and remarkably low for home health organizations based on this MyHIN data. Despite the relatively higher rates among skilled nursing facilities and inpatient rehab providers, it is notable that the vast majority of functions utilized for HIE are still limited to ADT, or admit, discharge, transfer notifications. This data corroborates our survey findings, including the relatively higher use of HIE to share ADT, medication, and laboratory information. Now that we've reviewed how EHR systems are currently being used in Michigan's long-term and post-acute care community, let's look at what providers are saying they want to get out of their systems. We found that most long-term and post-acute care providers are looking to get more out of their systems, and some noted a few opportunities for improvement, while others cited many different ways they could enhance their EHR use. Most commonly, providers reported the need to effectively integrate data from external sources into their EHR. This slide provides further detail on the EHR enhancements reportedly desired by long-term and post-acute care providers. At a high level, these fall into three categories: quality of care, patient safety, and operational efficiency. Studies have found these to be the leading motivational factors for adopting EHRs in the first place. These items also reveal how EHRs can promote public health. EHRs can facilitate quality improvement by reducing medical errors, providing easy access to patient information, and acting as a tool to engage patients in their healthcare. By providing alerts and reminders, EHRs can also lead to improved patient safety and reduced medication errors. When thoughtfully deployed in an operational environment, electronic health records also have the ability to promote overall operational efficiency when workflows and data are managed accordingly. Now, Sarah will discuss the challenges facing long-term and post-acute care providers in their pursuit of high-functioning EHR utilization.
Great, thank you, Andy. Next, I'm going to talk about some of the challenges we learned about in our environmental scan. Many long-term post-acute care provider organizations have not fully integrated technology into clinical operations, and providers also report frustrations with the day-to-day experience of using EHR and other technology to support care provision. Challenges identified in our scan fall into four categories described here: lack of interoperability, lack of incentive programs, lack of technical assistance and training, and cost and reliability factors. Issues were identified around interoperability, both internal to an organization and with external partners. Promoting integration of data at the patient level would be a gain. Many providers desire enhanced connectivity and tools to achieve it. Better management of physician orders, labs, medications are all sought after improvements. While interoperability is the most sought after enhancement, it is also the hardest to achieve. More support is needed for long-term post-acute care providers so they can achieve interoperability. In our survey, 60% of respondents said their highest priority is integrating data from external sources. Other areas mentioned are bridging communication gaps between clinical and IT experts to customize EHR, making sure clinical needs are clearly understood by IT folks, managing workflow while using EHR, analytics and informatics to track and demonstrate quality and to clearly show improvements, and addressing security risks and prevention of data breaches. And remember the 21st Century Cures Act I mentioned earlier? Now the ONC has published a proposed rule that brings more specificity to what is and is not information blocking. They want to implement interoperability without allowing providers to block each other and to maximize clinical processes. This includes external sources sharing complete, correct, and timely information about patients you are treating, and it's meant to improve quality and efficiency of care, and again, can be a factor in improving your ratings and reimbursement. Next, the lack of incentive programs brought challenges. In 2016, the Agency for Healthcare Research and Quality called for standardization of data in long-term post-acute care settings to enable meaningful data exchange. The AHQR also noted the new quality measures that will be much easier to measure and improve with interoperable data. Despite AHQR's recommendations, limited federal funds have been available to long-term post-acute care providers. Long-term post-acute care providers have, understandably, had slower uptake of full implementation of EHR compared to other provider types. The regulatory and quality measures we discussed earlier may make the value added of EHR adoption and use more prominent in long-term post-acute settings. Providers and experts reported a lack of available technical assistance and training for long-term post-acute care providers. Vendors do provide some initial training and ongoing assistance, but that often comes with a price tag and is usually aimed at a technical troubleshooting for immediate glitches. More technical assistance on EHR systems could improve workflows and allow easier quality measurement and reporting. The fourth area of challenge reported is cost and reliability of EHR systems. Costs related to initial purchase of EHR or purchase of enhancements, maintaining EHR systems and keeping systems in working order, reliability challenges reported related to infrastructure, including hardware problems and lack of high-speed internet, and delays related to EHR updates, with systems occasionally down for a time period during such updates. As you see in this chart, cost and reliability were the most cited challenges in our survey, but other items included staff resistance to change, which is not unusual with any new effort in an organization, loss of productivity during adoption or upgrade of EHR, the selection process, which EHR product is right for your operation, and the need for enhanced training. Now Andy will talk with us about some solutions to these challenges. Andy?
Thank you, Sarah. So we've talked about some specific challenges and barriers to EHR adoption and utilization, but the overlying theme of those challenges has always been the support for additional support with EHR systems. Our environmental scan found that the greatest challenge to EHR utilization, regardless of ownership type, provider type, or health IT management type, was the need for additional support with EHR capabilities, including assistance with utilizing EHR for interoperability, information exchange, and quality improvement. As we've discussed, our research identified key EHR utilization challenges, including integration of patient data, interoperability within internal and external systems, lack of incentives, and lack of support on how the EHR could improve workflows and help manage quality improvement initiatives. There's been an observed lack of currently available assistance to long-term and post-acute care providers, the provision of which could help overcome many of the challenges listed. We have found that offering technical assistance would be welcomed by providers, with most long-term and post-acute care providers agreeing that additional technical assistance for the enhancement of EHR utilization, above and beyond simply troubleshooting specific software issues, would be valuable for them. Finally, we found that upcoming regulatory changes and incentives may help to clarify the value add of EHR adoption. Incentives for EHR adoption and utilization have clearly had a positive impact for eligible providers when they were available. In lieu of similar incentive payments, helping long-term and post-acute care organizations obtain the value inherent in their EHR investments may lead to a more powerful EHR and health information exchange environment for the long-term and post-acute care industry. So we have identified the need for support, but what can we do to help? MCEDA has helped thousands of clinical providers in Michigan earn incentives under the Medicare and Medicaid EHR incentive programs. Our approach is to help clients understand how the use of their systems can be used to make sure the right data is available at the right time and is reported and recorded in the right ways to make sure clients are positioned for success in the changing reimbursement and incentive landscape. We have worked on numerous incentive programs to help our clients meet measures and improve overall efficiency, with expertise in a range of healthcare operations and regulatory requirements. We also are experienced in working directly with EHR vendors to fully understand the system capabilities, ensure functionality is enabled and working properly, and to communicate comfortably the needs of clinical providers to those vendors to understand how performance can be optimized. MCEDA was founded to provide EHR technical assistance to medical providers, initially under the requirements of the EHR incentive program, and over the years we have refined our approach to meet the needs of diverse types of providers facing varied and unique challenges. We're pleased to be able to provide assistance to providers in long-term and post-acute care settings. The following slides will provide a high-level overview of our process. Each participant who signs up with MCEDA will be assigned a specific health IT specialist representative for the duration of their participation agreement. This helps to ensure continuity in the service we provide. Our experienced health IT advisors deliver personalized assistance to meet the needs of participating organizations. We will determine the best approach based on initial and ongoing assessment. Ours is a data-driven approach, using quality metrics to guide improvement throughout the process. We evaluate your current state and educate personnel on EHR functions and utilization potential, how to accurately capture quality reporting data to represent actual performance, and the capabilities, metrics, and documentation needed to succeed in the changing value-based purchasing landscape. MCEDA uses a structured approach with built-in flexibility to focus on getting you the help where you need it the most. The discovery phase is how we get to know the specifics of participating organizations and their particular workflows to better understand how technology is used in real time. Once the current state has been assessed, we engage in goal setting with the organization to determine what areas of focus will best address their identified priorities. Based on the set goals, the next step is action in pursuit of those goals. We help to craft a plan of action and then work with participants to implement it successfully. Once the collaboratively determined goals and milestones are met, the action plan can be reassessed to facilitate continuous improvement at the organization. We hope that you've found this high-level overview of our research and technical assistance offering to be helpful. Would you like to know more? We'll be happy to talk with you. Contact us by phone, email, or visit our website using the information provided here. Additionally, if you are interested in more detail, here are further resources which can provide great information to you on the subjects we've discussed today. Thank you for attending. Now, we'll be happy to answer any questions you may have.
We have had some questions come in during the presentation. Again, if you have a question for our presenters, please type it into the questions box in your GoToWebinar interface. Our first question is, what does it cost to participate in this program?
That's a good question, Liz. Thank you. There are no direct costs to participating organizations at this time. The only cost would be simply the work and time needed from the organization to participate. As was referenced earlier, this is an initiative. We are contracted by the state of Michigan to help providers in long-term and post-acute care improve their EHR use for the purpose of making sure that information can be exchanged effectively and to improve clinical outcomes as well.
How long will we receive your help?
All right, yeah, another good question. So, it's difficult to say exactly because every organization is unique and exactly where they are in terms of their EHR implementation and the steps needed to achieve that higher functioning level of utilization and interoperability is going to vary considerably, but we anticipate the length of an engagement for each participant to be somewhere between 6 and 12 months to accomplish a set of realistic and mutually determined goals. Hopefully that clarifies enough.
Can we get your help with selecting an EHR?
Well, MCEDA is vendor neutral, but we are able to provide tools to help organizations evaluate merits of various software, things to be aware of and cognizant of in the contracting process, as well as the best way to take advantage of initial training and implementation provided by vendors. So yes, MCEDA can help organizations that are in the selection process. And remember, the often rip and replace process can be leave providers in need of assistance, and implementing a new or a changed EHR is also something that we're happy to talk with you about.
Where is MCEDA located?
We're a Michigan organization, and our headquarters are in Ann Arbor. We anticipate serving facilities and organizations across the state of Michigan, and that would be a combination of in-person visits and help and remote assistance.
What do you mean by helping with workflow?
Anytime an EHR is brought into day-to-day operations of an organization, it's going to change how processes are carried out. So new steps in any process can make or break the process. By evaluating the steps that the staff are currently using and the steps they'll need to do, the Quality Improvement Advisor can help determine what steps may need to be added or taken away to ensure the process is efficient and effective as much as possible. The idea is to develop standardized best practices, and standardized processes translate into increased patient safety and increased staff satisfaction.
What do you mean by incentives?
Another good question, thanks. And important to clarify. So, yeah, in the general sense, by incentives, we're referring to the potential impact of the changing value-based reimbursement, and those initiatives are expected to continue, as well as the overall impact and benefits of the EHR investment. It shouldn't be taken to mean that there are going to be incentive payments to participating organizations based on reporting and meeting objectives similar to what eligible providers received under the meaningful use programs. So it's not that kind of incentive. It's more just the overall incentive of performing at a high level to maximize your reimbursement rates and to get the most out of your EHR investment.
So those are all of the questions that we have for now. If we have missed anyone's question, we will email you directly with an answer shortly. Thank you everyone for attending and have a great day.